He is presently in private practice at Jorhat attached with 18 nursing home, Mission and Sanjeevani Hospital. The next panelist is Dr. Rajyoti Das, Professor of Department of ENT and Head and Neck Oncosurgery, Nebaoicon Cancer Institute. His special interest being a carcinoma of oral cavity, thyroid cancer, and recurrent cancer. The next panelist is Dr. Nebaoicon, Professor and Head of the Department of Oncopathology, Dr. Nebaoicon Cancer Institute. The next panelist is Dr. Nebaoicon, Associate Professor of Oncology, State Cancer Institute, Guwahati Medical College. He has 12 years of experience in the field of head and neck oncology, especially reconstructive surgery. Next we have Dr. Anupam Das, Associate Professor of the Department of Head and Neck Oncology, Nebaoicon Cancer Institute. Next we have Dr. Nebaoicon, Assistant Professor, Department of Nuclear Medicine, State Cancer Institute. And finally we have Dr. Milan Sinha, Radiologist from Downtown Hospital. I would request them to please be seated for the session. Thank you.
Thank you, ma'am.
Hello, good morning to everybody. Welcome to the final morning on thyroid cancer. So this is a cancer which is now on the rise all over the world, and here in our part of the country also we are seeing a rise in thyroid cancer, and most of them happen to be differentiated cancer. Fortunately, we get more differentiated cancers than the undifferentiated ones. Because in the spectrum of thyroid cancer, differentiated cancers have some of the best prognosis and outcomes amongst all the cancers, and anaplastic, on the other hand, is one of the worst in the spectrum amongst probably all cancers. So today, Dr. Ashok Shenoy from Bangalore. So he has already been introduced. Professor Shenoy, he was with the Kidwai Memorial Institute of Oncology most of his working life. After which he joined the Apollo Hospital there. Then a couple of years at the Mahavir Cancer Center at Patna. If you're ready, Dr. Shenoy, begin.
Thank you very much. I'd like to thank the organizers for having the last class. So I'd like to thank the organizers for having given me this opportunity to achieve. Yeah, this one. So both the chairpersons I have had the privilege of knowing for nearly 2 decades, and as I was talking to Manindra Bhai, we are all getting a little old, and we expect the youngsters to take the flag and be the flag bearers. Because we came in at a time where this specialty wouldn't have come to ENT. Let me be very frank with you. 2001, when we decided to start our own organization and try to rope basically the ENT people in, it was a very fortuitous move. Because had we not done at that point in time, we would have been, as a foundation, the recognized body in Indian subcontinent. It has been recognized by the IFNOS also. So we are the premier body, and now we have realized that anybody who has got interest in head and neck are welcome to come. We don't want it to be totally ENT, but it includes other surgical specialties, radiation oncologists, medical oncologists, because cancer is a holistic approach. One man cannot rule the show, as I will try to show you. So, welcome to my panelists. I am not going to go into the introducing them because they are already well known in this area. So I know that who are surgeons. Just give me a hand. Okay. So we have 4 surgeons and 1 pathologist. Who is the pathologist? You are the pathologist. And who is the nuclear medicine? You and you? Radiologist. Fine. That's a great panel. So let us go ahead. It's not moving. What's this? So this just tells you that we need to have a multi-pronged attack to see that this is we need surgical, it's mostly surgical. It is mostly, no, not this one. So it is mostly surgical, but today we have realized that thyroid is a gland where it goes first. Okay, that's it. So age is one of the most important prognostic factor, age and sex, and you'll all agree with me. There are no stage 3 and stage 4 cancer in patients below 45. I'm talking about differentiated thyroid neoplasm. I'm not talking about medullary carcinoma, which is totally different kettle of fish, and I'm not talking about anaplastic carcinoma. But in one gland, you see 3 different types of malignancies, and they all 3 behave differently. Medullary behave differently, it is going to genetic inheritance. You have thyroid differentiated neoplasm, which include the papillary, follicular, mixed. So you have many. One of the most important things is multicentricity. Everybody has talked about multicentricity, but the important thing is it's a very innocuous cancer. It can be multicentric, but I would like to ask RJ. RJ, can I call you RJ? Yeah. So can I ask you, despite the multicentricity, why is there a role for a lobectomy? In which situations could you have a lobectomy? Will you justify a lobectomy? You know that multicentricity occurs in nearly 80% of papillary carcinoma. That means both lobes are involved at the microscopic level.
If you go as per the guidelines 2015, when if your multicentricity is located in a single lobe,
Yeah.
still you can go for a lobectomy until the patient doesn't have other clinical or radiological high expense.
Now, even if they have, why you are justified in what percentage does it manifest in the contralateral lobe?
Yeah, percentage of orbital lobe is as low as less than 10%.
Excellent. So, this is the biology of the tumor. It has nothing to do with me or with Jyotidas or any of the surgeons. It believes that in a low risk group, we will come to the risk stratification. Microscopic cancer remains a microscopic layer. But what are the advantages or what are the disadvantages of lobectomy? Suppose he has done a lobectomy and he finds that he is a 30-year-old lady and what are the problems of doing only a lobectomy?
The main problem is if we think for total eradication, like radioactive that will be a problem.
Okay.
Because if it is lobectomy, we cannot go for that one.
Correct.
Another thing is recurrence.
Recurrence. But he said recurrence is less than 10%.
More than recurrence, issue is follow-up. The patient
Absolutely.
needs to be on follow-up.
Follow-up in what way? He has already told about recurrence. What are the other ways of detecting a follow-up? Recurrent disease.
Can I add something to that?
Yeah, please.
Because most of the time if you go for lobectomy, then it will be difficult for again if you need to surgery.
No, but you are cutting the isthmus. You are not going on the other side of your TO group. When you do lobectomy, you should stop at isthmus. You should not dissect the other TO group.
My point is that sir, if you are doing a lobectomy,
Yeah.
if at all that patient requires a completion hysterectomy,
Yeah.
and some of the cases patients who are very heavy comorbid condition, again
Okay.
going for second surgery will be difficult.
No, but this is hypothetical because most of the time we do it in a low risk group. So we assume that this will not behave. Okay, you are.
So, is the sensitivity of hydrochloric test for
Yes, that's what I would
lobectomy is not very good.
Absolutely.
Plus,
Both,
plus during a total thyroidectomy for a low risk patient, we will have to give thyroid replacement for the rest of our life, which has its own complication in the which may
that
have some
depends on the
complication.
endogenous thyroxine which is secreted by catalogue. It is functional also. I would say that you have to have a follow-up with ultrasound of the other lobe. That plus the marker makes it that much more difficult. And the last but not to least, if the patient should come for follow-up, it's so slow going, there is no symptom whatsoever. In fact, the lobe that you have left may not be palpable to the patient or to you.
What about if we doing a lobectomy for low risk group? So
That's what I'm saying.
Yeah.
But to follow up the contrast, that lady, let us say she goes to 80 years. Now she goes into high risk group. Then how? Don't think that the other lobe will not come back. That lobe will go into the high risk group. You think about this. I have had several patients like this, operated when they are 20, then they come when they are 70 with things like pathological fracture of the spine. And I do a CT scan and a FNAC from that, papillary carcinoma. So then we have to do a completion thyroidectomy 20 years later. But point is well taken that you don't have to give exogenous L-toxin right through the life. What are the problems of exogenous L-toxin?
Long duration manual suppression, most common would be cardiac problems like atrial fibrillation.
Okay, that you don't have to. You tailor it according to the T3, T4, TSH.
Osteoporosis.
Osteoporosis or osteopenia. Yes, osteoporosis is a very serious problem. So, then going on, you know that nodal impact, nodal metastasis has no impact, like in squamous carcinoma. If you have nodes, it halves the survival. Here it is not, unless per se the patient remains in high risk group. The extrathyroidal spread has got very important issues, and the grade of the tumor and histology. Madam, pathologist, the grade of the tumor, will you enlighten us? What is you mean by differentiated thyroid neoplasm, the grade of the tumor? Oh, so sorry.
Good morning, everyone. So, in cytology, we
No, not psychology, I'm talking about the histology.
histology
We know the psychology.
yes. So, differentiated tumor, these are papillary, follicular, and medullary. These are all differentiated tumor, and undifferentiated anaplastic tumor.
No, the grade of the tumor. You see, the age is classification.
Yes.
Gives the age, grade, extent, and the distant metastasis. So, what is the grade? In the papillary carcinoma, there is something called a grade, which was floated by the Mayo Clinic.
Yes.
Have you want to enlighten us on that?
Actually, that is grade well differentiated. Grade 1,
Yeah.
grade 1, grade 2, grade 3.
Grade 3. So, as the differentiation becomes less, you are saying it becomes more aggressive.
Yes.
Am I right? So, that's the point. But it depends from pathologist to pathologist. Am I right? Yeah. So, what one pathologist says is high grade may not be low grade to the other. So, just remember that it's like your leukoplakia. When one person says carcinoma in situ, the other person will say invasive cancer, and the patient keeps on going around surgeons and pathologists and getting disturbed. So, let's go on.
Another thing is, you report on FNC only, because we do only FNC, not fast types. That is why I think grade.
No, when we are looking at this, this we are looking at the final result. How it will prognosticate. We are not going there. Now we will go to the other area. There are microinvasive cancers, less than 1 centimeters. To treat or not to treat? Any of the surgeons want to take that call? If you see in a 40-year-old person, 1 centimeter microinvasive cancer in the left lobe, the other lobe is, for all practical purposes, it is by CT scan also negative, I mean there is no disease there. Will you treat it or will you not treat it? There are some centers in the world that do not treat it.
Actually, sir, the term is that most of the cancers, in the micro cancers are indolent. They just stay there throughout the life. The issue is that once you see a 1 centimeter or less nodule, if you go for FNAC and it comes out to be carcinoma, the word carcinoma will dictate the patient to approach a surgeon, and if I don't operate, someone else will operate.
Okay. So then what does it require? It requires awareness on the part of the surgeon, so as to make the patient also aware that there is nothing to lose sleep over. Can you suggest any study that has been done anywhere in the world I'm giving you a clue, where they have just looked at 1 centimeter. Ethos group has done in Kurumi Cancer Center. They have kept them, but they have found from the follow-up that 30% of them will change behavior, requiring a lobectomy. Okay, so you have, Japan is a very learned place, high educational status. You can, by your social worker, will be able to track that patient down and get him to the hospital. They have social security and all those things. So they can get the patient in. Can we do the same in SM? No. So I would agree with it. That yes, madam, you go ahead.
Yes, sir. According to ATA 2015 guidelines, micropapillary carcinoma less than 1 centimeter, if it is intrathyroid, and whether it is unifocal or multifocal, we can maybe keep the patient on follow-up. But if the thyroid has got lesion, has got extrathyroidal extension, then definitely treatment is required.
But can you make out with your ultrasonic, your sonologist, right?
Ultrasound.
You can make out that this has got extrathyroidal spread?
No, that is mostly with FNSC only.
Only FNSC?
Only FNSC, yes, because ultrasound is highly sensitive for detection of nodes in the lateral compartment, but not very sensitive in detection of mediastinal disease.
Not mediastinal, I'm talking about the gland.
Yes, mainly extrathyroidal is with depends on the pathologist.
You can make out the location of the nodule within the gland also. So
yes, that is
you can make out whether it's going towards the TO group, very close to the esophagus.
In adjacent soft tissue structures,
yes,
we can make out with ultrasonography also.
But what
the radiologist can be.
No, but what you cannot make out, what about the central compartment?
Central compartment and central extension is the posterior compartment.
No, it's difficult to make out with ultrasound.
Yes, sir. That is for CT. Then we have to go for CT scan for medication and other things.
Yes, absolutely.
One more point I'd like to add.
Yeah.
If we detect the micropapillary carcinoma, if we detect it by ultrasound, if we detect it by CT scan, if we detect it by PET scan, out of these 3, PET scan has the highest sensitivity of the malignancy. So if we detect PET scan detected microcarcinoma, at least we can go for ultrasound to see whether there is a undernormality of nodules or not.
No, the point is the sternum is there, that's the problem. You know, it does not allow. Now they have started doing ultrasound on the table.
No, I am talking about the neck, sir.
Neck.
Microcarcinoma.
Yeah, you can shed light. Radiologist. You can also give your expert opinion, sir. Yeah.
Microcarcinoma, 1 centimeter.
Yeah.
Is nearby recurring laryngeal now.
Yes.
And to recall, without the knowledge of patient, there may be recurrent nerve.
Absolutely right. I have seen such cases. Absolutely. This is experience talking. If the disease is 1 centimeter, but it is on the medial side and abutting onto the recurrent laryngeal nerve, even though it's micropapillary according to book, it may cause the recurrent laryngeal nerve palsy, and then you have problem because that recurrent laryngeal nerve you cannot revitalize. Whatever you nerve graft, anything you put. Okay, you wanted to add something, madam?
No, sir.
You want?
Yeah, right. In ultrasound, we can see the margins and extracapsular extension of the nodule. While looking at the margins only.
Yeah.
Then plus in PET, I think there is like.
No, let's not go to PET because we are saying in, we are in one part of India which is, which is not in a high-tech center where you can send it to PET and it costs so much of money. I don't know how much it costs here.
So what I would like to add is that for micro-invasive papillary PET is not the ideal modality in the initial stage.
Not as a first treatment.
And not as
first treatment. You tell me ultrasound and CT scan. I'll agree with you.
CT can detect extracapsular extension, extrathyroidal and central compartment node especially.
Yeah, you can do it. I agree. Anybody wants to add something to that?
Microcarcinoma as per illegally, we have to see after the mixed papillary also. If you say microcarcinoma, as yes, whether it is microcalcification or not.
Yeah, I'll come to that. I've got slides on that.
Presence of lymph nodes or
Yeah, I'll come to that.
sense of treating.
I will come to that. Jyoti.
Can I just add
Yeah, please.
something what Dr. Gurwa mentioned just now about the proximity to the recurrent laryngeal nerve. Now that is probably the reason why we should be more careful about posteriorly based tumors in the thyroid.
Absolutely.
Because these are the cancers which, as he said, will, very insidiously, without knowledge, will enlarge and spread into his tracheoesophageal groove and cause these problems.
Okay. Okay. So we will now go on further. We have important thing in the world. The disease has more than doubled all across the globe. But in the last 30 years it has tripled. That's what the world literature, CM data, this is American data. We don't have our own personal data. But the death has remained stable. Can you give me the reasons for this? One of the surgeons. Can you tell me why, despite the incidence becoming more, why you are not having the mortality also mirroring that increase in incidence? Go ahead.
So for this, there's kind of two theories. One is actual increase in number of cases, and second is actual increase in detection of subclinical cases. So in the West, it's kind of a thing, all the patients are insured and all. So every patient generally go for ultrasound follow-up every year, kind of a routine checkup. So this leads to an increased early detection of cases. So even by literature also, they've said that the number of CT scans or ultrasound that have been done over the years has gone up substantially. So the reservoir pool is being increased.
One point is this.
And there can be sometimes, there can be actual increase of cases because maybe change in like radiation exposures because of the CT scans and all.
No, but the mortality is not increasing.
Yeah, that's because that's most of the time the increase in cases we see, it's not the advanced cases that have been detected, it's mostly the early the microcarcinoma cases that has contributed to this increase.
The increase in cases have been only in those less than 1 centimeter. That is the interesting thing.
The thing is that more of the CT scan, ultrasound, and imaging done for other diseases, which detects the incidental.
Incidental.
If you do not detect the incidental, it's going to say in the same indolent way.
Correct. I get your point. It is both because of incidentalomas, incidental findings, and also that you are seeing disease much earlier. These incidentalomas are caught at a very early stage with a much better prognosis. So you are operating this, and then you now know the biology of the disease. Now you know the value of adjuvant treatment. I will come to that also. But we know a lot more about thyroid cancer than we did know 20 years back. I tell you, when I started, I didn't know much about thyroid cancer. But today I believe that is what Dr. Shah says, that thyroid cancer after total thyroidectomy is a laboratory cancer. That means you can control it sitting in your armchair with a couple of blood tests. You can control the guy right through. So that's important. So let's go on. We are here to practice cost-effective and evidence-based medicine. We want to optimize our resource utilization. We want to cure our rates, that is the high, intermediate and low. In the lower group also you will have about 50% 20-year survival and to minimize unnecessary morbidity. So in the interest of time, let us go once to the atypical presentation. Would you like one of you, one by one, Jyoti, what is the most atypical thing that you have seen in thyroid? In all these areas, what are the things that you have seen which brings you to mind that this is really, you never thought it was thyroid and time you get to the thyroid? Can the thyroid manifest as a node with no thyromegaly?
Incidence is very low.
Incidence is low? No.
Yes, sir, we have seen.
You have seen. Parapharyngeal mass, you stick a needle, capillary carcinoma. Come with a fracture, they do a FNAC, it turns out to be.
There was one research case presented with a mandibular mass.
Mandibular mass. A mass in the scalp. So you can have everything. Everything, these are atypical unless your antenna is up. You will not be able to.
We quite frequently get, in fact occasionally get referrals from orthopedics department with spinal mess.
Correct. What about a node in the neck, and if FNAC says NAC, neuroendocrine carcinoma?
Not very uncommon, so recently we have.
What does it look at? I mean, I'm not talking about this, but you should rule out medullary carcinoma in such cases. Okay?
Those are the cases, those are the cases where
you get a diagnosis, if your antenna is there, that patient comes into your department and under your life and it improves your chances of a better reputation because thyroid cancer is worthwhile operating. Even in distant metastatic mode, it is worth operating. You all will talk to that.
So I remember one case who presented with dengue and diarrhea. Presented to Sir Raman sir. I still remember his name. The name was Nebaoicon sir. I still remember it. For around 2 years. Eventually, all tests were done. Eventually, we found that the calcitonin was raised and the diarrhea was because of calcitonin.
Okay, so that's it. That tells you that it is a thyroid carcinoma and medullary carcinoma, right? Yeah, correct. That is, so we have gone through. I would like to just look at this part. In high iodine, moderate iodine and low iodine, you have a difference in the prevalence of papillary versus follicular. Has this been, is this very relevant?
Here, yes, sir, because we have Manipur nearby to us. And in Manipur, it's a low iodine belt and papillary carcinoma is extremely high.
Follicular carcinoma is very high?
I think papillary.
Follicular also. Follicular is more. And follicular is more biologically aggressive than papillary. The biggest paper that came out in this country was Dr. Rao's. And it came out in a big journal, I think it came out in Indian Journal of Surgical Oncology. He looked at follicular carcinoma and he said that this is definitely not same as biological aggressiveness the papillary. Do you also agree? Follicular you will treat it more aggressively?
Yes.
This is an important message I would like to give it to our colleagues. Again, now we look at the patient, tumor, histology, markers. Within the interest of time, will go fast. What are the reasons for increased distant metastasis? Can you, I'll come one by one, I will tell you the reasons, but if you can give, before I come to that, Jyoti, what are the, why you are seeing distant metastasis as a first manifestation or some manifestation during the course of the disease? The course of the disease may be 15 years, but sometimes you will see the differentiated thyroid with distant metastasis. What do you think is the cause?
Thyroid is aggressive.
Yes, that's right.
Thyroid is aggressive. Presence present in the renal is good.
Yes.
The patient has a lot of asthma or muscle leg nodes.
Okay.
Those are the factors which increases the distant metastasis.
Anything else?
Vascularity.
Yes. Vascularity, extraterritorial.
Okay. Anything else?
One would be follicular carcinoma, distant metastasis is more.
Yes. Okay, so let's just go for the interest of time. Is it a changing behavior? People are found in the United States, not so much here, but the poorly differentiated variants of differentiated diameter in elderly age group is more associated with different distant mets. Is it changing biology? Is it higher awareness on our part? We are doing what we call incidental and picking up. What has impacted this? Again, it is technology. And other thing is, once we have something, you know, have markers also. You have tumor markers.
Breast disease.
Yeah, BRCA, BRCA, B600, these are all there. So this is the reason, if you have a BRCA positive, the chances of a distant spread is very high. You can predict it, but can you do anything about it? Except give them more surveillance and maybe you will do a more aggressive search for distant metastasis with iodine, the post-surgery iodine. Okay, so ultrasound and FNAP ushered in a new era of heightened awareness. You already discussed it, so I'll go through. What are the high risks of ultrasound? I just asked this for the benefit of youngsters. You can tell me 1, 2, 3, 4, 5. And the score, that is the PISA score.
Thyroid score is used by American College of Radiology. So we look mainly at 5 things: the composition of the nodule, whether the nodule is like completely cystic, or spongiform appearance. Spongiform and cystic are considered benign. Spongiform lacking honeycomb appearance. Then we have got solid are more suspicious. Then we have the margins of the gland well defined, ill defined. Then the echogenicity, hypoechoic are they are suspicious. They fall in the suspicious species group. Then we see for microcalcification equilibrium foci. And the shape of that land, tolerant line or wider than tall. Those are the
so there are well-defined period score. And every ultrasonologist should be, and also the surgeon should also see. In America, most of the surgeons, they will have ultrasound suite, and they will take that ultrasound and they will check it out together with the sonologist, so that you will know what is the characteristic that swings the pendulum towards malignancy. Yes?
So nowadays, without an IS score, it's said to be found in ultrasound for child.
Yes, absolutely.
And it has to be mentioned in ultrasound.
Yes, you're right. I was just going to say that. Thyroid has to be complemented with the ultrasound and FNAC, I would say. I would go further than that and then add the FNAC.
Dr. Saab, the importance of elastography.
Yes, you can answer that. I'm not sure.
Elastography is a new technique, so like it's not available in this one. Then elastography mainly sees the solidity or the cellularity of the nodule. So if a nodule is more stiff or hard, which we can pick up in ultrasound, it suggests more like malignant features.
It's a new technology and it requires different software, but yes, there is, yes.
It has also been a scoring system mostly used by the Koreans.
By the Koreans, yes.
And it has not a standard of investigation now, still now.
So ultrasound is the standard of care, and if the gentleman has a software which is a little higher, then they will be able to tell you that elasticity or what do I call that. I am not very conversant with it. It is popularized by the Koreans mostly, and they have found the patterns which will tell you that this is highly suspicious. So it's a pointer to tell you to search for the. So this question I asked and we already answered it, so we'll go on to the next one. We will. Okay, so for the benefit of the people, the Bethesda scoring, Madam, you would like to the coverage, so sorry.
Yes. So from 2017, from 2017, the Bethesda system is introduced for diagnosis of thyroid cancer. So there are six categories. First is non-diagnostic or unsatisfactory, when the follicular cells are very less. Usually 6 groups of follicular cells should be present for a diagnosis. So if it is cellularity is very less, then it is unsatisfactory or non-diagnostic. Then we advise for a repeat FNAC, where the ultrasound guided repeat FNAC. Then second category is the benign category. Benign category like colloid nodules or pericardial nodules or Hashimoto's disease. These are all benign categories. So here we advise for clinical follow-up with ultrasound. Then the third category is the atypia of undetermined significance or follicular lesions of undetermined significance, where we can see few atypical cells, but it is very difficult to say a malignant. So here we can advise for a repeat FNAC, or we can advise some molecular tests also. Now some molecular tests are also available, so we can advise some molecular tests.
You advise molecular test for AUS?
Yes, we can.
How expensive is it?
These are actually PCR based tests, so they are quite expensive.
Correct. So really, this may not be cleanable in our setup. Maybe in Bombay, Delhi, maybe Bangalore. I don't know.
They should collect cases and do it.
No, I don't do it. It's easier to do a locatomy.
Now I think with the collaborative laboratory work, laboratories here are collaborating with laboratories in Delhi and Bombay, and they are beginning to do these. Especially perhaps clinicians they already doing it.
So can I do one thing? Yeah. Suppose the patient is a celebrity and very well-known person. In your Bethesda 3 and 4, I think this works for convince them to counseling to go for a better cell or the person back.
Again, it depends on you. If you are a big thyroid surgeon, that's a different story. But if you are doing occasional thyroid surgery, then you will take the support of all these things.
But for other people, there is something medical issue also there.
No, there is no medical legal. There is no medical legal, but it is to have a good rapport with your patients. See, the issue is they should be told first and above that this is not a cancer that kills overnight. It is not a cancer. You get second chances, you get third chances. For the patient, you should convince them. I know it is difficult to convince, but you should have a rapport with them right when this comes. Am I right, colleagues? Do you have people coming and complaining to you that you have not given me FLUS and then it has turned out to be cancer? If you have told them nicely, you should tell them. The surgeon should tell them.
Moreover, these tests are not 100% diagnostics.
They are largely diagnostic. I will come to that.
They will give you an idea regarding how to treat the patients.
So I don't want to go into that in this forum because it is really high-tech, really high-tech. I have got slides, I have hidden the slides because I told Ari, let me get to the basics of surgery. So, number 3 and number 4 will be coming under indeterminate. And then you will be very careful to the patient and have a dialogue with the surgeon. If the surgeon feels he can also err, if it's a unilobar disease, you can do a lobectomy, and if you can do a good job, you got the thing in the bag, cap in the bag. So nobody gets tense over this. So I would really like to send this as a pointer to our young surgeons that when a pathologist gives this diagnosis of AUS or FLUS, FLUS is more associated with malignancy, but you must be very clear that the patient understands that this disease is not going to kill. It is a disease that you can attack again and again without damaging the guy's voice or his life.
When we need to correlate the ultrasonography or
Of course. By the time you go for FNAC, you would have done the ultrasound.
That's why I think you can explain, you can counsel the patient also.
Of course, that's why people say the lobectomy.
Ultrasound doesn't show any heart expand or anything, goes having something.
No, but you take this with the education level of your patient. As you said, if he's a very educated patient, he will ask 100 questions for you. Yes, very important. Counseling, yes. But at the end of the day, the final histology is what is this. If there is nothing there, they will say you have done an unnecessary surgery. And in the process, if you have any complication, then you are in a suit. How a good surgeon you are. And it can happen in anybody's hands. Please tell the last commenter that go ahead.
This whole slide is the risk of malignancy. This is one point that is the percentage chance of each of these categories turning into malignancy.
I will just take you to the next slide. This is what it says. The concurrence between central cytopathology and the AUS, FLUS, there is a lot of difference. See, this is a big study done in the US. There is agreement when you do AUS and AUS both ways is 35%. Here you see it is 66% the situation. And the suspicion of malignancy climbs down again. When you are sure on your evidence that there is a suspicion of malignancy, it correlates. But here is the biggest jump. So you should know which regions to avoid surgery. That's the main thing. But if there is any doubt, please do it. I don't think it's a big thing doing lobectomy. A patient will, at the best, thank you if you do an uneventful lobectomy. Again, this will come to later. This is the one that I showed. FRMA. If you do the FRMA, it takes out this part of the cases that you will tell them that you do not need to do a thyroid exploration. And it cuts it down. In the FUS and ATPR, it tells you that which are the cases. It's a rule out test. So there is a rule in test, there is a rule out test. I don't think it's very relevant to our practice. I'm telling you, in Assam or in Bangalore, I don't do it. Even if it's a very high-flying guy, I had certain several cases like that. I feel that if you talk to them, because at the end of the day, you do a FMR, rule out, and somebody else does the surgery and then he turns up with follicular neoplasm, what answer you got? So I don't die hard, it's always, these are all tests, studies done in big hospitals.
Diagnostic antithyroidectomy costs less than an normal test.
Correct. So $6,000, $8,000, Jyoti is telling me. I have never sent a single one there. But it depends anyway. And then after doing total thyroidectomy, how do you assess the response to therapy? Excellent response is when you have no clinical, biochemical or structural evidence of disease. Biochemical incomplete is thyroglobulin. I have talked to you about thyroglobulin and antithyroglobulin antibodies. Can you say a word about antithyroglobulin antibodies? When do you do that? After total thyroidectomy. I am jumping straight.
Both thyroglobulin and antithyroglobulin tests should be done at the same time, so that we know that there is no difference between the tests. However, the rate at which the antithyroid antiglobulin falls is less as compared to the TG level. So that is one thing to consider.
So whenever you have a very high thyroglobulin level, you have to do the antibody level also. The structural one you know about, where I don't have to tell you progressive disease and how to detect it and come to that. And the indeterminate is the most difficult because you don't have, you have everything is non-specific. And the patient has got symptoms or he's got issues and you don't know. This includes patient with stable or declining thyroglobulin antibodies with or without evidence of structural evidence. So these are difficult to follow up situations and therefore I will just now go on to the risk stratification. We'll go on to this because this is the most important paradigm in decision making. As I told you, less than 45, they all fall in the intermediate or low risk group. And if it is more than 45, if it is more than 4 centimeters, if it is extraglandular, and if the grade is high, the distal metastasis is present, it all falls into high. But remember, even in the high, 20-year 5-year survival is about 50%. 20-year mortality rate is 50%. So it's, and in low risk, it is 95%. So please understand that this is what you have to understand and communicate to the patient that don't worry, you will not have an issue. And in this sort of a situation, your surgery assumes a lot of importance, especially if you have complications like what are the two complications, graded complications?
Nerve injury and parathyroid.
And
parathyroid.
So we'll go to that. And then if we have time, we'll go to radioactive and then close the shop. I've already come to 1 hour, so I'll take another 15-20 minutes. So that in the utility of central compartment clearance and this, would you like to take that? Jyoti?
Central compartment is the first group that is involved.
What is the indication for central compartment clearance?
As per entry guidelines, central compartment indications are T3 and T4 tumors. And there is
T3 and T4 tumors.
T3 and T4 tumors. And if there is any positive necrosis detected either in personography or CT scan.
In the lateral neck?
In the lateral.
Okay. What about extrathyroidal spread?
Extrathyroidal spread is spread in cases of low grade tumor, low stage T1, T2. If you are going for an lobectomy, you need not go for a
extrathyroidal itself takes it to higher stage.
In upstage, yes, upstage.
So,
at least we should go for an inspection of the central compartment.
Everybody agrees. You also agree.
Now, one thing is saying rather than going for an inspection, you should explore the central compartment. Because inspection is
okay. Then indication. Just ask me. I'm asking you now. I'm putting the thing into your mouth. What is the issue once you have a central compartment issue? What are the problems of central compartment if you have nodes there? How do you determine whether they are just reactive nodes or they are metastatic nodes or they may be a parathyroid for God's sake? They are hypertrophic huge parathyroid. So it is something that you cannot take lightly. I think that's the most dangerous part of the surgery. Am I right, Munindra? Prophylaxis. We come to that. Prophylaxis.
Main complication in central compartment is hypotension, injury of the glands. Secondly, the nerve injury.
Nerve is not so much, but
Not so much.
parathyroid is definitely. We'll come to that. So let me put the thing. This is a thing. Now, what I want to ask Saitya is, when you do a indirect laryngoscopy or a FOL post surgery, what is the incidence of transient recurrent laryngoscopy or transient it's paramedial? You have done before surgery, it is all right. After surgery, you are sure you have preserved the nerve, but the nerve is not moving.
Sir.
The voice is gone.
Yes.
Let him do it and I'll talk.
Sometimes we get neuropraxia.
Yeah. What percentage?
Very high.
Very high, yeah, it is very high.
Very high.
It is quite high, it's 20%. It is 20% is very scary.
But after 2 days, usually it comes back.
How many days? No, not 1 week. No. It takes anything from 1 month to 3 months. That is provided you have the anatomic integrity with the microaspiration.
If it is only because of edema or minor.
No, you have saved it. You are a great surgeon. You will save it. You will photograph it. You will do everything. But you are sad. Functionally, it is gone.
Another thing is after 4 months, sometimes we get still nerve is not moving normal. Voice has already.
That's because of compensation.
Yeah,
That is
the patient is satisfied.
No, but at the end of the day, you may go to Jyoti in Guwahati and Jyoti will write in his notes, gone. No. Then you are in trouble.
So main issue of doing a pharmacological diagnosis is to see whether it is detected or undetected nerve. Because patient might not have any voice but he or she might have a nerve. That is measured by compensation. So there will be symptomatic nerve pulse, there will be asymptomatic
No,
nerve
I'm
pulse.
saying the position of the nerve is paramedial or cadaveric at the end of your surgery by discharge. Okay? But you are 100% sure that you have preserved the nerve.
So we can follow the patient and restore it.
What percentage comes back? What is the incidence of permanent recurrent laryngoscopy nerve palsy?
50% comes back.
So how much is the permanent recurrent laryngoscopy nerve palsy?
Small actually.
It's one, less than 1%.
Actually, sir, we have published a series of around 265 patients from Guwahati Medical College. There we had a transient palsy of around 10 or 11%, I don't remember exactly. And out of them, 1.5% did not come back.
No, that's it. Transient and permanent, there is a 20% gap, so please be careful. And while you can encourage them, there is something called ischemic injury, which is something that you cannot predict how the things come back. So it is important, first and foremost, when you have finished your surgery, you take out the relaxants and take the scope and have a look at it. If it is moving immediately after surgery, the later on, if it stops moving, it's due to neuropraxia. If immediately you have no movement and it's the only functional nerve, then what do you do?
That's a tricky point. If anyhow you have to go for a combination surgery, surgeon has to be over-cautious. Because completely one nerve is
But if you are overcautious, you will not be able to do a therapeutic CCD, central compartment clearance.
My point is that sir, if the patient has already got a symptomatic nerve pulse,
Yeah, he's already got, you are operating on the only functional nerve side.
Counseling.
so counseling for the injury,
What other precautions you will take?
you can take a help of the nerve monitor.
Yeah, do you have any experience with IONM? Intraoperative nerve monitor.
No, we don't have sir.
You should have it. You should have it.
Because these are very necessary in cases of reduced surgery.
If there is a loss of signal when you are operating, you are supposed to stop there and come out. Just come out. And then do it another day, counsel the patient and do it another day. Because if you damage that now, possibility of airway distress is going to be there. And then that becomes a very, very serious issue.
Even nerve monitor will help us to say whether we are living behind a structural nerve or we are living behind a functional nerve.
That your IONM will tell you.
That's the help of the
IONM will certainly tell you. And also the DSCOP at the end of the thing. patient, you are on a safe level.
Redo surgery and retired cases is very useful.
No, redo I have done, I will show you that also, but it is very risky. It happened to me and I went back, I was 100% I reintubated, I had a look at the nerve, showed it to everybody, photographed it, and I said, patient afterwards required a tracheotomy, but in 3 weeks you could decapitate. So that's a different thing. And that is only in hospitals where you have other colleagues helping you. If you are the lone surgeon in Jorhat, for instance, there may not be anybody to support you. What are you going to do? It becomes very difficult. So you have to have good interaction with the location of the parathyroids. A word about that. We did a study of 80 odd cases. We looked at the parathyroid. We found that on the left side, it's almost always lateral and posterior superior to the recurrent laryngeal nerve, the parathyroid. Because left side, the RLN goes into the thorax and ascends. And the location of the recurrent laryngeal nerve is recessed in the tube groove. So the inferior thyroid artery is never at risk. Whereas on the right side, you have obliquely placed recurrent laryngeal nerve. So you have the disposition of the superior right is almost always lateral in anterior superior plane to the RLN, and inferior right is equally medial and lateral to the RLN, but on a plane anterior mostly rather than posterior. So you have to know this, and it is a good idea not only to do INM but also to use loops. If you use loops, I use loops. Since last 15 years, as soon as skin go, I put the loops. So if you are going to do, and what is the trick to preventing parathyroid ischemia? That's for you. That's what is the trick? What is tell your junior? That be careful, let this vascularity of the parathyroid not get jeopardized.
Proper handling of the tissues to keep the diaphragm away from the.
Some other thing. The inferior thyroid artery is blood supply to the parathyroids and then goes to the thyroid. So you have to keep the inferior thyroid artery after it leaves the parathyroid, the medial aspect of the parathyroid. Remember that.
Because it's selective ligation of the
But this is not possible all the time. Remember that. Especially on the right side.
As far as possible, we should identify themselves.
No, you identify, of course you identify. Then you identify, you don't ligate frontal. You go identify the parathyroid and then go medially. And then you have to push that parathyroid laterally. This is very important. And this you can do better both with nerve stimulator if you got and loops. I would advise everybody to invest in a loop which is very expensive, or 2.5 lakhs, but it is worth it if you are going to be a hardcore head and neck surgeon. For parotid also it's worth it. It's worth it in your microvascular anastomosis also. So it is something that you will not regret buying. So these are the two things you must know. Okay. We'll go on to that next. Yeah. This is a video. This is the preservation of AV plexus. So I am showing you. This is the parathyroid. This is the medial aspect where I have not done, and this is the recurrent laryngeal nerve. I will show you the other picture very well. So this is what I wanted you to understand. Here. This is the nerve, which is on a deeper plane. And this is the artery. I preserve this artery also. The medial aspect, I don't cut it. I leave it there. And this I can do only on the left side. This is the left side. Left interjugular vein. So make sure that this AV plexus around the nerve, you see there it is. You can see that it is going into the peristegument side. So leave it there. So these are the ways to handle. And on the left side, it is facilitated by the lateral location of parathyroid. On the right side, it is not like that. The parathyroids may be superior or inferior, and usually it is in the plane You know that. So because of the descent, as developmentally descent, these are like that, this is the recurrent angle now. So very close to the entrance of the recurrent angle now, you have a superior parathyroid. And inferiorly, you can have median, unlike the left side. So be careful. On the right side, it is at a much bigger risk than on the left side. The right side, if you've got a thyromegaly and you've got a big disease there, then at this point in time, you have to be very careful and you have to, this area, which is the point of entry of the nerve into the, under the cricothyroid muscles, this you have to be very careful on the right side. So right parathyroid damages are much more than left parathyroid. This is the actual study we did. This is what it looks like. It is the recurrent laryngeal nerve with the trachea. Most of them are here on the right side. It is lateral and it is above or below the recurrent laryngeal nerve. On the left side, it is lateral. So the blood vessels come from here. Blood vessels come from here. So you can safely save the microvasculature to the left parathyroids very well. So left, you can be very careful and you can be quite confident. But on the right side, you have to be very careful.
Can I just...
yeah, please. You want to go ahead?
Actually, it's about the parathyroid only. If you are not contemplating a central compartment neck dissection, you dissect on the surface of the lobe and take the fascia away from the lobe, and you are always never going to be wrong. You can always save the parathyroid in that case.
Absolutely. That is another.
Yeah, it's only when you are doing a central compartment neck dissection, it's a different story altogether. That's why you have to be very, very careful.
No, even if you take central compartment is at this level, EO group. All your parathyroids are lateral to the recurrent laryngeal nerve on the left side. Next time when you are doing a thyroidectomy on the left side, remember me. You will see what the veracity of my thing. The nodes, paratracheal nodes are usually hugging the EO group, unless you got huge ones going into superior mediastinum, that's different. But subtle 0.5, 3 millimeter nodes, they are all between the two recurrent laryngeal nerves. And the other point that you said is most of these are subcapsular location, parathyroid. So as soon as you get into the thyroid capsule, you can push the thyroid capsule, it's an intracapsular dissection where the parathyroid is. And you may leave slivers of tiny thyroid tissue with your radiation, radionuclide group, and you're the radionuclide nuclear medicine. She will say that there is very much a lot of tissue in the TO group. If the Lord knows can, she will tell you that this is the issue. So don't have to get very disturbed about it, because if you want to preserve parathyroid, there may be little bit of, there's nothing but total thyroidectomy, that's why they use the word near total thyroid. You want to add to that? What percentage of thyroid left in the TO group will show in the gamma camera scan?
If this uptake is more than 2%, then we can say that it is a large membrane.
At how many hours after the 5 microcuries?
Sir, usually we do not have to give 5 microcurie. Even with 100 microcurie or
large dose diagnostics.
Large dose diagnostics, and usually 1 to 2 millicuries is sufficient to prevent stunning.
And you have to wait for how many hours?
At least 48 hours.
48 hours. If there is more than 2%, these colleagues will write in the report that there is residual thyroid tissue in the TO group.
But what I would like to add is that large remnant always does not mean that it is the disease tissue. It might be due to normal tissue also. Paper is
there is no way of finding that out.
Yes,
There is no way of finding that out.
yes.
There is no way of finding that out.
This is what is called surgical ablation.
Surgical?
Ablation. So when there is a first nucleus and when there is a uptake is less than 3%. That is almost all microscopically seen tissue has been taken by the surgeon. So this is a term called surgical ablation, which was quoted by Dr. Shah.
Shah plays, but I think you should recognize and respect the sentiments of our nuclear medicine.
And so nowadays uptake is actually usually done by an iodine probe. But most of the private hospitals, even government medical institutes, do not go for the probe. Because that is
gamma camera probe.
yes, sir. But it is an additional technique.
You just explain it to them.
Yes, sir.
They have understood. What is earlier case and what is now?
Yes, sir. Earlier in government institutes, like in Tata, RMC, BFC, they use an uptake probe to determine what percentage of thyroid remnant is there. But that is a different technology altogether. And many centers now what they do, they just do imaging under gamma camera. And if we immediately do not send the patient, if there is a small remnant, very large remnant only, we can send the patient there. Because immediately sending patient for a small remnant, that is nowadays mostly done visually. We see the remnant, and if we see that it is okay, we can go for a higher dose therapy, then we need not send them the patient to the surgeon. If we see 2-3 foci, 3-4 foci, and then a lateral neck nodes, uptake on lateral side of the neck, then only we can send the patient to the surgeon.
It cannot be admitted.
No, it can be updated. It can be updated.
Radioiodine ablation will proceed.
Okay, now I will come to you, madam. Dr. Bal from AIMS has said that radioiodine ablation in patients who have got disease in the contralateral and are considered high risk for surgery.
Yes.
What is your opinion on that? Please explain to them. What is the situation is, I have operated on a patient, she has got disease and now she manifests with disease in the contralateral lobe which was not touched. But it has started to grow. And the vocal cord is intact.
Yes, sir. Contralateral nodes should always go for USC guided FNAC. And if it comes out to be metastatic and the nodes are surgically resectable, then definitely before radioactive therapy, the nodes has to be resected. But if FNAC is not metastatic disease.
No, it is metastatic, but the patient is high risk.
Yes.
Let us say on that side there is only functional recurrent angina.
Yes, metastatic neck nodes, surgically resectable should always be handled by the surgeon before delivering radioactive iodine therapy. Then only the radioactive iodine therapy will be fruitful.
He is asking about total lobar ablation.
Total lobar ablation.
He is asking about.
So total lobar ablation, as per FDA guidelines, if the patient has undergone only lobectomy, then we actually FDA does not recommend radioactive iodine therapy.
But Dr. Bal recommends
Yes, sir. Bhaskar is doing some experiments. He has published some studies. He has published some studies.
published also.
Yes, sir. Yes,
No, I am telling you,
So this is the only
lower ablation by
Yeah.
radioactive iodine has not accepted by the international body.
Yes, yes, that is what
it
it
is.
is.
In certain situations, patient is considered high risk for surgery. That side has got the only functioning recurrent angle nerve.
Maybe you can use this large
Yeah, you have to use.
If we go for radioactive iodine also, we have to give high therapy, high dose therapy, yes.
Not 30 micrograms.
We could not, no, 30 microcurie not.
100 micrograms.
150 to 200 millicuries.
But this is the only study which is done by Bal for lobar ablation has been accepted by J guidelines.
No, it
He
is.
has done all cases of more than 300 plus.
Yes.
True, I agree with
The
you.
APA guidelines still does not
No, it
recommend.
depends. I told you, the patient is very sick, doesn't want to work, decides not to work, or it is the only functioning nerve that's it.
So comorbidities and all.
Yeah, then if by mistake something happens, then you have to face the music.
So the problem with radioactive iodine therapy in lobectomy is that radioactive iodine will be mostly taken up by the normal thyroid cells rather than the cancerous cells.
Service study, this has been accepted by International Society also, the study of the pump.
Yeah, but not practically.
It is not the type A recommendation, it is type C.
Type C.
No, it is not type C. It is not the high.
We cannot expect the therapy.
But I just told, in case you have a very old patient on wheelchair, patient has got vocal cord palsy on the side of the lobe that you want to look at, then better to go for a
But this is
consult.
not about practice by ablation centers in India or
Yes,
abroad. So
yes,
the AIMS has practice.
Yes.
No, but he has got very good results. Again, the results are because it's indolent cancer.
No.
And
So you can argue till the cows come home. You
And
argue,
sir-
you can keep on arguing.
And sir, if patient is already old and wants survival for a few years, then that will be
Okay,
the last.
now madam, indications for radioiodine and then we will go to indications for exogenous thyroid suppression. These two will close the shop here. I think we have gone through most of the things. If any questions, audience want, which I have not dealt with because I have got about 100 slides, I can't go through it. But these two, if you can take, and we will, our surgeons can also add. When do you refer for radioactivity? When do you refer for, what is the prerequisite before the patient you give radioactivity?
Yes, before patient preparation after total or near total thyroidectomy, mainly we should not start T4 or T4 approximate if we want immediate treatment. First we tell the patient to wait for 3 to 4 weeks. Then because after 3 to 4 weeks patient will check serum TSH. Why we need to check serum TSH? Because first we have to know the mechanism of radioactive iodine uptake in differentiated thyroid cancer cells. Differentiated thyroid cancer cells express sodium iodide synthetase, which is a glycoprotein. So, a mechanism of uptake of radioiodine in thyroid cancer cells, differentiated thyroid cancer cells, is mainly through the sodium iodide synthetase. It is an active transport mechanism. So, what is these sodium iodide synthetase are usually located in the cytoplasm of malignant thyroid cancer cells as well as normal thyroid cancer cells also. So we want the THS level to be greater than 30 microinternational unit per ml. A cutoff value of TSH greater than 30 will re-stimulate, it will cause translocation of the sodium iodide synthetase from the cytoplasm to the plasma membrane. Then only radioactive iodine uptake will happen. This is the first thing we need to tell the surgeon or the patient. Secondly, when will the TSH reach 30 microinternational unit per ml, patient has to avoid iodine containing food. Iodine containing food means mainly iodine containing multivitamin, iodine containing cough syrup, some seafood. Seafood we usually do not, patients usually do not take in Assam or even Manipur and all. Seafood, and we tell the patient not to take extra salt. Patient can tell the patient to take the Tata's iodized salt. It is not that patient has to avoid salt totally, but should not take extra salt in the food. What we say kacha nimok or kesa nimok na lagaw. We say kacha nimok mat khana. Otherwise, whatever salt is added in the curry or dal, that is okay. So, and patient after surgery should not apply betadine also. Betadine ointment may also avoid the iodine uptake. So, and before giving therapy, we have to check the blood count and serum creatinine level. Why serum creatinine level? Because if there is renal impairment, then iodine will not be excreted through the kidneys. The main route of excretion of iodine is through the kidneys within first 48 hours and then only fecal excretion. So if there is a renal impairment, then patient will be exposed to the radiation effects of radioiodine. These are the things, and when patient will come for scan, we also check the serum thyroglobulin level and anti-TG antibody.
Any importance of blood sugar?
No, not much in iodine, only with FDG PET.
Madam, you have to give me one more, that all these, the dosimetry for radioiodine, whether you are happy of following your whole body scan, very minimal, but surgeon is not happy. He has cleared paratracheal disease, he may have left some microscopic disease. To satisfy the surgeon and to corroborate, is it a possibility to give 30 microcuries to prevent the stun effect of the radioiodine? You can explain to that to the colleagues also.
So, meaning the stunning issue.
Yes.
Stunning issue is what? If we give a large dose of iodine 131, first dose scan which we do, that is called the diagnostic dose with diagnostic scan with low dose iodine. That activity should be 1 to 3 millicuries as per ETA guidelines. So what is stunning? Stunning is a biological phenomenon in which the diagnostic dose will impair the uptake of radioiodine in subsequent therapeutic dose. Meaning to say that if we give higher dose of iodine 131 like 5 millicuries as diagnostic dose, which is not required, so that radioiodine emits some beta particles. So beta particles will temporarily damage the sodium iodide synthetase. So when we give the therapeutic dose, there will be 50% reduction in the uptake. That is why we say that you should avoid extra iodine or iodine containing food. Iodine intake should be less than 150 microgram for 1 week before starting the large dose scan. That is one way to prevent stunning. Another way to prevent stunning is to use iodine 123. in place of iodine 131. But iodine 123 practically not used in India.
Not available.
Because it is cyclotron produced. We need a cyclotron. It cannot be produced in the reactor like iodine 131. So practically iodine 123, and it has got shorter half-life also, but better diagnostic imaging quality. But iodine 123 we cannot use to prevent stunning because of some practical difficulties. We use iodine 131 with low dose of iodine, 1 millicurie, 2 millicurie is enough. And if we give the therapeutic dose within 72 hours of the diagnostic scan, then we probably usually
avoid stunning. Okay, now madam, for lack of time, I'll just, how often do you, after you finish all these things, is there a role in patients whom you do not want to wait for 4 weeks for the serum TSH to go up? Can you use any new technology that is there to give it immediately after thyroid?
In that case, we can use recombinant TSH. But it is a costly thing, but if patient is affordable, we can go for recombinant TSH. Then we can avoid the complications of hypothyroidism and reduce the duration of patient stay due to complications of hypothyroidism.
Yes.
No, not in my center. In my center, but in India it is used. AIMS, Tata, BRC.
I use it because my patients, if they have to get back to work and they don't want to be hypothyroid and mentally subnormal, because hypothyroidism causes dullness in the mind. They will not be able to work.
Yes.
It is only 90,000 rupees. You will earn that money in no time instead of sitting at home. So I would ask madam, if you have clients who are want to get back to work, educated people, traveling people, I'm not talking about Aam Janata, but persons who are on the go. So you should do it. I don't know why you are not doing it.
Yes, we are doing in centers outside Assam. In many government institutes are also doing. So protocol for recombinant TSH is a very short duration procedure. Day 1 and day 2 we will give 0.9 milligram of TSH, D5M. Then on day 2 evening we can check for serum, send blood sample for serum TSH thyroglobulin. If serum TSH is more than 30, definitely it will come more than 30 with recombinant human TSH. Then day 3 evening we can give the scan for dose for diagnostic scan, and day 4 we do the scan. And day 5, day 7 thyroglobulin and anti-TG antibody and give the therapeutic dose.
If the patient
give full ablation here in this institute?
Yes.
Ablation percentage is same.
No, it is better. No, it is better, Pukanji. It is better because the intensity with which it takes on radioiodine is very strong. The therapeutic dose is fully utilized there. So
patient is having extra some distant metastasis.
Only in the brain. If you have
if patient is having distant metastasis, then the TSH level will not rise at all because there is functioning mass already in the body. Even if you keep the patient off approximately for 4 to 6 weeks, TSH will only be 3, 4, something like that. In that case also we can go for recombinant.
In that case, if there is a functioning metastatic thyroid issue, in those cases, TG will rise.
Yes, definitely.
TG will rise, and in certain cases, TG may not rise at all, especially in older people. These are non-secreting tumors.
I'm saying in function thyroid.
These are non-secreting tumors. That is why you need the FTG PET to find out whether you are harboring metastasis. And this is probably a role for the medical oncologist to come and start sorafenib or serafenib to make it again iodine avid. There is a lot of work being done by Tuttle and company in Memorial. When they give the serafenib for those that are not thyroid area, those poorly differentiated lesions, Dr. Veera told you.
What I would like to add is that if TG rises high and the thyroglobulin, usually we come to PET scan. If that is in case of tennis syndrome, thyroglobulin elevated, negative iodine scan, but TG more than 10 nanogram per ml, that is stimulated TG more than 10 nanogram per ml, that is the main indication for FTG PET scan.
So I am telling about immediate metastatic disease. A functioning thyroid issue in those cases TG will rise.
Yes.
If it is a metastatic disease without a functioning thyroid tissue, in
a lot, and then you have to do this.
will go for this.
Yes, yes.
All those will go.
Yes,
No,
yes.
those will go for your tyrosine kinase
Yes.
therapy.
Refractory diabetic therapy, we can go for tyrosine kinase inhibitor.
Okay, the last word about how much of alkoxin to give post-op for the benefit of the youngsters. Because when I was a postgraduate, we used to give 300 milligrams MCG.
Yes, previously we used to give 300 microgram, but now the dose has been reduced. We usually start with 50 microgram for 1 week, and then gradually we increase the dose up to 150 to 200 microgram. Previously we used to give to 300 was the standard
But
previously.
do you go by the TSH levels?
Yes, yes.
How much do you want to keep it in the low risk group? How much do you want to keep it in the intermediate risk group?
And high
And how
risk.
much do you do in the high risk group?
Yes, so suppressed teaching for low risk group, they say it can be up to 0.5 to 2.
1 to 5 can be there.
Yes,
That's normal.
non-normal range.
Yeah.
Yes, and intermediate risk group, they say up to 0.5 to 1.
Yes.
And high risk group should be less than 0.2.
Absolutely. 0.1.
0.1.
So you have to titrate your alkoxin dose according to your TSH. Don't overtly suppress because it is not needed in the low risk group.
Yes.
Only in the high risk group you try to give, and that's why your dose to suppress the pituitary axis, the TRF and the TSH, that is biologic feedback occurs. So you have to be careful. Tell me, what is the advice to the patient if you after ablation, how often does he have to see you for a repeat large dose whole body scan?
Repeat large dose. For ATA low risk group, it says that patient can only be followed up on TGN with anti-TG antibodies, need not go for further radioactive iodine therapy up to 6 months. For ATA intermediate risk and high risk group, after 6 months we first follow the patient with stimulated TG only. Although ATA guidelines say that we can monitor the patient on non-stimulated TG, but for patients' benefit, future benefit.
Now please tell them what is stimulated and non-stimulated.
Stimulated thyroglobulin is when we keep the patient off entroxin. For 4 to 6 weeks, then thyroglobulin level will rise. That is stimulated TG. Non-stimulated, if you are keeping the patient on entroxin, then TG level will be within normal range. It will not rise. Like TSH stimulates the sodium iodine syncotas, TSH will also stimulate the thyroglobulin. Thyroglobulin is also a protein, and it will TSH stimulates the thyroglobulin. That is why we say stimulated TG.
Okay, I think this is enough for it has been a wonderful session. I think I have overshot by half an hour. That is a permission I took from German Talukdar. Thank you for that half an hour, because I thought that our boys and girls should know how to follow thyroid. Thyroid is a curable disease, especially differentiated thyroid, and you owe it to your patients that sitting in the armchair you can treat the laboratory cancer. Thank you, big thanks to all the panelists, and of course my good friends Kudoshi and Munindra ji and the August audience. I thank you for giving me the opportunity. I have tried to give you a state of art, but without going too much into the moleculars, because molecular I took out the slides because I think that will be just intellectual gymnastics. And none of us do FMA or all those things, so there's no point doing this. But recurrent angel now, parathyroid, radioactive, with radioiodine activity, it is a big tool. It is a big tool. It is if it is absorbed well, 1 gram of thyroid tissue metastatic functional will ablate the thyroid tissue to 10,000 bands.
Thank you, Doctor.
Am I right? I have read a lot of radioiodine, and Paul is a good friend of mine.
Yes.
Time is.
Yeah. Thank you very much,
Before concluding, Dr. Sanai has explained very nicely, elaborately. And one thing is important, the incidence of thyroid cancer is less than 1% in the human body. And still we discuss everywhere, mainly in head and neck or surgical oncology or the ENT, thyroid is a subject for it. But why we discuss? Because thyroid nodule we have to investigate whether it is a benign or malignant. That is the basic principle in thyroid. And another important point is that whether we will go for surgery or wait for observation. So for benign disease, we may observe. For malignant disease case, we have to do a therapeutic therapy. Therapeutic therapy means lobectomy or total thyroidectomy, depends on the situation or the risk factors and all. Another important point that Bethesda, which has been discussed today very extensively, that Bethesda will fail now because there is another entity which will come to the Bethesda. It is NIFT. That is non-invasive follicular neoplasm, thyroid neoplasm with capillary-like features. That will come, and that is a very indolent sort of things. Maybe a lobectomy is
a low risk group.
It's very low risk. That immediately will come. And another thing, that age group 45, below 45, and above 45, that will also come to 55. Because people have observed that below 45 and after 55, that results are set prognostically. So maybe they will include the age group also up to 55, not 45. And another important point that Kubar has also asked me, that yes, for a malignancy there is no problem. For a benign disease there is no problem. Problem arises in 20 to 30% patient in a os, flask or the follicular lesion. That is the important issue. Whether just like Kubar is saying that some celebrities, maybe a service celebrities or UK celebrities come, then what you will do? Because if you when CAT scan has come in Guwahati, hardly 1 or 2 doctors have prescribed. Now everybody does get that stage. So it is not available till now, most probably in Guwahati. But in this group, os, flask or follicular neoplasm, maybe we have to do the follicular markers, which says that there were 95% sensitivity and specificity, which is very good to rule out or rule in. The person has already explained that rule out or rule in means if molecular things are positive, you have to go for surgery. And if it is negative, you get well. With this feel like I think already we are late. I thank Dr. Sanayaki and the other panelists, and thank you very much.
I would like to request Dr. Paramita Chakrabarti ma'am, Joint Organizing Secretary Nebaoicon, our moderator Dr. Ashok Sinha sir. Now I would like to request Dr. B.T. Border ma'am to discuss our panelists. Panelist Dr. Pradeep Saidya sir, Dr. Rajeev Das, Dr. Anupam Sharma, Dr. Mridul Sharma, Dr. Anupam Das, Dr. Vindapani.
Slide please, slide.
I would request the chairperson also to come to the dais.
Chairperson, please.
Mobile side please.
I would also request Dr. B.T. Border ma'am to felicitate our chairperson, Dr. Kudu Shaman sir, Dr. M.N. Bola sir. quiz session. Thank you.
Penultimate program of the final program is a very victory. So this is the penultimate program of Nebaoicon 2020. So we are running in 2022. There has been a lot of last minute entrance or new groups in the quiz. So what we have decided to do is see how many of them are present. Maybe we will modify the groups a little bit because we actually do not want to eliminate anybody because each has been prepared with questions for 5 groups. So it's just in half an hour it's not possible to create more questions for 8 groups and 8 becomes 7 classes. So we will try to see how many of the groups are here. Dr. Vivek Agarwal will call up the names of the participants. And could you please come forward with your names and all? Maybe we will make the groups into groups of 3, depending on the presence. But we don't want to eliminate any group, so that it becomes more fun with everybody else.
Dr. R.K. Gupta. Dr. R.K. Gupta is here. Dr. Tanushree. Please come forward.
Dr. R.K. Gupta and Dr. Tanushree, if you are here, please come forward.
Dr. Gopi. Amrita Gupta. Dr. Kritika. Kriti Khandelwal. Dr. Gopi. Just meet all the team. Dr. Sahib Ahmed Mujumdar. Dr. Sharmista Talukdar. Dr. Sunani Goswami. Dr. Arnav. Dr. Kapon Sharma. Dr. Sonali Pandey. Dr. Pallavi and Dr. Pallavi. Dr. Navroz and Dr. Sarun. Okay, Dr. Siri now.
From downtown DMV group, you are from Silchar Medical College again. From Guwahati Medical College, from Assam Medical College. Then we have got 2 participants from Negri and one from Assam Medical College. No, that is the already we have 1, 2, 3, 4, 5, 6. We have prepared for 5 teams with a contingency in the 6, but now we have got the 7. that is a real problem. There is one solution, irrespective of being in a particular institution. We could, allow maybe if the house doesn't have any objection, to allow them to participate. They can join up with any of the teams they decide.
I think the best solution, yeah.
I think it's the best solution. It may not be in the name of it. You can join up with, we can make 4 in a team. You know each other. There was another lady who wanted to be. Yes, you can join up with your teammates here. There will be 4 people in sub teams. There will be 3 people in sub teams. Baton to Vivek Agarwal to conduct the quiz. Okay, everybody settled? Please. So this is group A, the first group. And so please introduce yourself.
I'm Dr. Gopi from Nebaoicon Campus Hospital.
Good morning, I'm Anuradha from Nepal.
It's a BPCI group with one name.
Preeti from BPCI.
Everyone, I'm Dr. Ashok from BPCI.
Good morning, Hello.
Good morning, Dr. Ashok from AMC. Good morning, Dr. Parvika from AMC. Good morning, Dr. Suhani from AMC. Good morning, Dr. Eliza from GMC.
Good morning, my name is Dr. Navos from GMC.
Good morning, I'm Dr. Sharon from GMC.
Good morning, Dr. Musitra from GMC.
No more will Dr. Nisha from Physiotherapy.
Good morning, everyone. I'm Dr. Tanushree and I'm from City Medical College. Good morning, everyone. I'm Dr. Ashmita Gupta from City Medical College. Good morning. I'm Dr. Saya from City Medical College.
I'm Dr. Arif from Damdar.
Good morning, I am Dr. Tapal Sharma from Dr.
Good morning, this is Dr. Sonali from Ramana Hospital. Good morning, I'm Dr. Pallavi from Jawaharlal Medical College.
Good morning, myself Dr. Mirza Majlislam from Jawaharlal Medical College.
Good morning, myself Prachurya Kambali from Legends.
So we are all set, and I'll put the score. Vivek will start the presentation. Please.
We were supposed to start
And all the best to all the participants.
It is 10:54. We'll start now. Just to reconfirm, I'll name all the teams once. This will be Team A, Team B, Team C, Team D, Team E, Team F. Okay? So. The first line is the most important, others are not so important. There's no negative marking. You'll get 15 seconds for each question, which are direct. Once the person the team cannot answer it, pass it on to the next team. You'll get 5 seconds. For each direct question, you get 10 points. For each past question, you get 5 points. In all the rounds, only the first response from the team will be considered and accepted. So the team has to decide and then answer. It's not that all the 4 of you can answer and then one of it is correct. Okay?
And the Quizmaster decision is time.
This is for the audience.
No problem.
So, there will be questions which nobody can answer, go to the audience, and there will be prizes for that. One humble request to all the participants and the audience, kindly switch off your phones. No searching on the wall, Google and giving answers. Okay? So we start with quiz with round 1. Round 1 is tall words. So what we need to do is, there will be pictures given. Each team has to identify the person. Full names. Nicknames will not work. So the first question goes to Team A. Time has started. Decide. Who is the person?
William House.
Wow. Team B?
Chevalier Jackson.
Yes. I'll give you the point. Already enough to give you the full name. His name is Chevalier Jackson. He is the father of endoscopy and he was from US, Pennsylvania. Just 5 points to Team B. The next question is for Team B. Time's going. He's an Indian living outside. Team C.
Jatin sir.
Correct. So next question is going to Team C. You've got 5 points. Identify. He's an Indian living in India.
Ikrus sir. Dr.
Full name?
Ikrus.
Full name. But I'll have to give it to you. This is Sir Anil Ikrus sir. 10 points Team C. Team B. This question is for you. But the person is also related to obstructive sleep apnea.
Your subject.
Time out. Team E. Team F. Team A. Any guesses? No negative marking. Team B. No guesses. Team C. Okay. Goes to the audience now. Anyone in the audience?
We must not know this subject is
Even if it is not the subject, I will not answer.
See, got a motto on some switch, I did not give answer. Yes.
Who was that?
Somebody said treatment. Yes, sir. Satyajit.
We have a classification to it and obstructive sleep apnea. The next question goes to Team E. Team E. Here's the question. Correct. Padma Shri Sri Radhikanan sir from the chart. Next question is Team F. European. Team A. Any guesses?
Biggie means European. Yes, though.
Very cold country. Team B. Team C. Any guesses? Team D. Okay, someone here will say Team E. Audience?
From Germany.
Okay, that brings us to the end of the first round. Let's have the scores, please. This is for our audience. Who can identify him? I got a great person.
Audience.
Japanese. Yes, yes. Focus, sir.
So team A hasn't opened the account, team B is on 5, team C is on 15, team D hasn't opened, team E is on 10, and team F hasn't opened the account.
Okay, round 2. Team A. Okay, so this is sort of a radiology round. Each question has 2 parts. You'll have to answer both to get full marks, or you'll not get half marks. If it passes somebody, so if you have said something correct, the person can capitalize on that and still get mark points. Name is pathology and what sign is it called? Team B, any guesses? Okay.
I will tell.
So next question also team B.
Hormone sign, juvenile respiratory angiofibrosis.
She got both of them right. Next question goes to team C. Where do you get this sign? And what is it called? Team D. Any guesses? Team E. You take a guess, no negative one. And people message. Team F. Team A.
Chopstick sign in JNA.
Yeah, post-op. Post-op sign. Post-op sign. Where it was next question goes to D. Okay. Team D. Identify the condition and explain it in what a short 1 sentence you can say. Concentrate here. No guesses? Team E? No, I said concentrate here. Team F. Okay, it's a child. Team A?
Facial nerve adhesion. Adhesion of the facial canal.
Team B?
Corner septum.
Team C?
Bonding.
Yes. Can you explain it? What is bonding?
Just complete formation of the complete length of
Correct. 5 marks to Team C. Next question goes to Team E. Any guesses? Time out. Team F.
Lateral center.
Team A. Team B. C. D.
Give some hints.
It's too easy.
Too easy. Quick method, very knowledgeable.
Done. Audience?
Thunder.
Anyone in the audience?
Paragliding.
What else was it? Anyone in the audience?
Is it sort of nearby? Something else? Nearby. Very good thing.
To me, it looks like a tadpole, but it is not that.
We like a tadpole, but not a tadpole.
Okay, I'll give one name. A comment sign or a tail sign. Comment tail sign. Diagnosis? Okay, I saved a coffee for myself. Is it permitting to do that? Okay.